Good morning. Good morning, my lady. Could I ask, please, for the witness, Professor Buchan, to be sworn, please?
I swear by Almighty God
That the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
Could you please tell the inquirer your full name?
I'm Professor Ian Buchan.
Professor Buchan, you've prepared a witness statement dated the 31st of March 2025. It's 23 pages, and we see your signature on the last page. Your statement's dated the 31st of March of this year. Can I ask you to confirm are the contents of that statement true to the best of your knowledge and belief?
I confirm.
Thank you. Can we first of all start, please, by identifying your background, qualifications and career history? I'm going to summarise it, but please, if I don't do justice to it, please feel free to elaborate. It's right, isn't it, that you are a public health physician of some 23 years, but you're also a data scientist, and you work to harness data and technologies for patients and populations.
That's correct.
But you've also got a medical qualification as well.
I do.
You are also the inaugural W.H. Duncan Professor of Public Health Systems at Liverpool University,
I am.
where you're also the Associate Vice Chancellor for Innovation. And significantly, the largest proportion of your evidence today is going to be in respect of what we will call the Liverpool pilot. It's right, isn't it, that you led the evaluation of the government's voluntary open access mass testing with lateral flow devices in Liverpool from November 2020?
That is correct.
Thank you. It's right, isn't it, that you lead Liverpool's Institute of Population Health as part of that role as the Executive Dean, but you also manage public health partnerships with local authorities and the local NHS trusts?
Yes. At the time of the COVID-19 pandemic, I was partly deployed as a public health physician, working with my colleagues in the National Health Service, local public health teams, leading on the academic input.
Thank you.
And as Executive Dean of an Institute of Population Health.
Now, your statement also tells us that you were the lead academic member of the COVID-19 Gold Command team overseeing testing for Liverpool City Council, Liverpool City Region Combined Authority, and NHS Cheshire and Merseyside. And is that in respect of the Liverpool pilot?
It is, yes.
Thank you. And then additionally, you tell us in your witness statement that you are an investigator for the Health Protection Research Unit, is that correct? The National Institute for Health Research, but also you're an investigator for UKHSA.
Yes, I'm an NIHR senior investigator, and I support a Health Protection Research Unit. During COVID-19, that was for gastrointestinal infections, but it pivoted to COVID-19. I'm now part of the Emerging and Zoonotic Infections Health Protection Research Unit.
And do you continue in that role to present day as an investigator?
I do.
Thank you. Now, we're going to come to deal with the Liverpool pilot and the findings, and as I've already identified, that related to November of 2020. But can we first briefly look together at a SAGE paper from the 27th of August 2020, because obviously that predated your pilot and the findings, just to identify if any of those themes chime with what you found in the Liverpool pilot. Please could we display INQ 61561? Thank you. And so if we move forward within that document, please. It's paragraph 18, please, where we find the observations that SAGE provided in advance of your pilot around mass screening. If we could go to, paragraph 18, the next page, please. SAGE found that the effectiveness of mass testing will depend on several factors, including the proportion of the population tested, the frequency of testing, the ability of a test to identify true positives and negatives, the speed of results and adherence to isolation. It is important to recognise that testing is one part of a system leading to isolation of infectious individuals, and the whole system needs to work in order to achieve the desired aim, which would be to identify as many infectious people as possible and isolate them from contacts during the infectious period. And perhaps just to complete the context, if we could go to the next page, please, and paragraph 22, the SAGE document also records, with mass testing, it will be most efficient and effective initially to concentrate increased testing capacity on high-risk groups and settings where transmission is likely to be greatest. Priority groups for mass testing should be identified according to the risk of individuals being infectious and the potential consequence if they tested positive. For the system to work, social and economic factors will need to be considered, including incentives and interventions to enhance adherence. And so, Professor Buchan, just as a general principle, could I ask you, we can see that that document identified that testing is just one part of a system that leads to isolation. And does it follow from your perspective that mass testing should be considered as one potential component of a wider, robust TTI system alongside properly planned and resourced contact tracing and isolation and effective use of asymptomatic testing?
Yes, my colleagues in this meeting from the 27th of August 2020 rightly recognises that testing is more than a test. It is a whole system. It is a system embedded in a community that requires tracing around people who test positive, the understanding of why that tracing is important, effective means of isolation, including support for people in isolation that consider social and economic factors. That is a whole community, whole system approach.
Thank you. Okay, then I ask you additionally, do you have any view as to whether potential mass testing initiatives should be modelled as part of scenario planning for pandemic preparedness?
Yes, it's very important to rehearse a whole system approach, to involve the communities. We have very rich public services that have deep relationships with their local communities, particularly local public health teams. And that diversity, my military colleagues describe it sometimes as distributed resilience. Having a network of strong communities is more powerful than one hub for preparedness with lots of spokes that wait for a command from the hub. The battlefield needs to keep on fighting the battle if it's cut off from the war room. And that is offered by our local public health teams.
Thank you. Now, by way of headline, we're going to come to deal with the Liverpool pilot, but was it your experience from the Liverpool pilot that SAGE's view were completely supported by a need for a whole system approach as your pilot identified?
Yes, there were many conversations. As you can imagine, it's a very fast-moving situation where evidence was generated very quickly, within 5 weeks. Actually, I reported the interim findings on the 10th of December 2020, after the pilot had begun on the 6th of November 2020. The findings included some deep information about inequalities, financial and digital poverty being a barrier to accessing testing, as important information that should shape how community testing was done. It also became apparent that the most useful kind of testing was a tool that communities could take themselves and organize around, so self-testing. Earlier in the year, the offer had been testing that needed a laboratory, other kinds of testing. So a lot of evidence generated quickly.
Well, we'll come to the findings and the interim report and then an updated report. But can you now take us through how it was that the project developed? And you start the chronology, just to give the context of the project, from the 31st of October 2020. And I think it's right to identify, by way of the broader context the inquiry have heard, this was at a time when there was consideration being given to Operation Moonshot. Mm-hmm. We know that we are approaching the time where we went to the second national lockdown on the 6th of November. And so with that brief context, and as you've already highlighted, the trials that were taking place with the new testing device, lateral flow devices, could you give an overview to the Chair of the lead up to the project and then what you did in the project, please?
On the 31st of October 2020, I received a call from my colleagues to have a conversation with government. There was an offer of testing with military assistance twice weekly, targeting 3/4 of the population. We said immediately that that was an unrealistic target. We couldn't achieve 3/4, and that testing had to be invited in by the community, has to be understood by the community if it was to be sustained. That was accepted, that a more community-based approach could be shaped, and that the military assistance would be from a Gold Command run by Liverpool City. It was a very productive conversation. We also looked at the evidence emerging on the effectiveness of lateral flow devices that was presented in that meeting, and considered it and put together the MAST, or the Mass Asymptomatic Serial Testing Protocol.
Thank you. Now, can you then, just for clarity for the Chair, give an overview of the organisations that were involved? You tell us in the statement that it involved colleagues from the Department of Health and Social Care, colleagues from Public Health England, academics from the University of Oxford, but in addition you had the local resources of the local public health teams, the directors of public health, and the local trust where obviously patients were being admitted with COVID. Are there any other key stakeholders, as well as the police and military, that were involved in the pilot?
There's very much a team effort between the stakeholders that you've mentioned. But one of the most important stakeholders was our local communities, the community leaders. And they were represented by public health professionals, wearing my own public health hat. And with my director of public health, we channeled the needs of our communities and promised to take back to them an initial design of how the pilot would work, and only to proceed after that consultation.
Now, it's clear from your statement that you worked at speed. The request came in on the 31st of October. You've just explained the MAST protocol that you then developed over the 1st to the 5th of November. But whilst we deal with MAST, you go on to tell us within the statement that you changed the approach from MAST to SMART, systematic, meaningful, asymptomatic, repeated testing. Can you just explain what the difference is and why it matters, please?
It's a really important word, meaningful. The meaning to our local communities is vital. If they were to take testing to protect themselves, their families, their workplaces, and their wider community. One of the early pieces of feedback was that serial wasn't understood, so that was changed to repeated. Meaningful was emphasized. Asymptomatic, finding people who didn't know they had the virus and could pass it on, was accepted. We wrote a paper about this in the British Medical Journal. But in the process of putting together SMART as a protocol with greater community involvement than had been anticipated, I think, at the offer of military assistance for testing, there was a lot of really useful work and thinking put together in a very short period of time. It was actually 5 days that the initial protocol for how sites would work, where someone turned up, would swab themselves whilst being observed, hand the swab to staff. It could be a military person, it could be a civilian person who'd been trained to use the lateral flow device. And then for quality assurance, the lateral flow device was processed in a standard way, and that went for data to be generated to come back to the research teams.
Thank you. And can we just then deal with the lateral flow device? We know that they became in common use after your trial and as part of the community testing project. But can you help us as to which lateral flow device was being used as part of the trial, please?
At the time of the pilot, we weren't told which manufacturer was involved. We did know that a number of devices had been tested by Public Health England, Porton Division, with the University of Oxford, and the highest performing device was selected. Actually, the evidence I presented to SAGE on the 10th of December 2020, I put pictures of devices because we thought there were two manufacturers. There were different packaging. We had to scrape some of the codes off to investigate what were we comparing one device. The little strip that goes in the device, we were assured, was from one manufacturer. It was just a different plastic packaging that they'd put together. It was only later into the trial that we learned the name of the manufacturer.
But can we perhaps then summarise that part of the trial was to effectively assess whether lateral flow devices were suitably sensitive and specific to identify COVID. Is that correct? Because at that time, the gold standard test that was only being used was the PCR lab test.
Yes. What we needed in public health was a test of infectiousness to tell people that there were signs from a swab that they'd taken that they were likely to breathe out virus that was viable enough to pass on and infect someone else. The gold standard PCR test is a gold standard for a medical diagnosis. Has a patient presenting with these symptoms of COVID been infected with the SARS-CoV-2 virus? They may no longer be infectious. In fact, there are many days after which a patient is no longer infectious that a PCR test would be positive. And we may need to get those people back to work that may be in a key role that's important for society in a pandemic. So we really needed a public health test of infectiousness and not a clinical test of having been infected.
Thank you. Now, you describe in some detail the systems of data and data flow that you utilised as part of the trial. And can I ask you to explain that to Her Ladyship, in particular, the Combined Intelligence for Population Health Action System that had been uniquely commissioned in Liverpool, please?
Yes, one of the most important parts of an effective pandemic response is that all of the agencies are on the same page with live data, combined intelligence, so that the actions of tomorrow are informed by the data of today. We put together a new system across Cheshire and Merseyside because there wasn't a linked general practice, hospital, public health testing data system. There wasn't one integrated database. That would normally take several years to put together. It was stood up in summer 2020 in 90 days by an excellent team. And it really did have the effect of helping those agencies to work well together to a common set of timely information. During the pilot of mass testing, we also combined military intelligence around footfall. Colleagues from the British Army measured attendance at testing centres, the feedback from people running those testing centres. So that live sharing of how things were going could also involve moving a testing site. We looked at geographical information that came not only from NHS data, but from other sources of describing a neighbourhood. We had indicators of digital poverty for neighbourhoods, and that proved very useful. We were able to show that people in financial poverty and in digital poverty were more likely to get COVID and less likely to get tested.
Thank you. Now, you've indicated that do you say CIPHA system, or is it that had been approved by NHSX in the spring of 2020, but that was the system that was utilised in the pilot. And you say this, that it essentially gave a feed of COVID-19 test results from the prototype national system, updated every 30 minutes. And you've helpfully extracted into your statement, I think, the dashboard as displayed. Can we display that on the screen, please? It's page 6 of the statement, and it sits in paragraph 14, please. And could it be expanded? So could I ask you, Professor Buchan, is that what you were seeing, real time, being updated every 30 minutes during the pilot?
Yes, it was. Here we see the lateral flow test results and the PCR test results, the different peaks or the different waves as the virus evolved throughout the pandemic. Many colleagues use this as a single point of reference. They would look at it each morning and it would help create conversations. You see the big upswing from the Omicron variant, the very large peak there, the end of 21. At that time, a quarter of NHS staff were off work in isolation or quarantine. And the attention to these dashboards at this point were acute. We also had dashboards on staff absence from key roles in the National Health Service.
Thank you.
So this is a very live conversation.
Now, you've already headlined your interim report and then a later report, but there was a significant sticking point, my description, in respect of access to the data. Would you agree? And rather than me summarising it, could you explain to the Chair what the issue was around data and access to the data, please?
To look at the effects of mass testing on people being admitted to hospital with severe COVID, we needed to create comparator groups to Liverpool. There was no town or city exactly like Liverpool at the time. So the best practice analysis of the data is what's called a synthetic control analysis. You create an artificial Liverpool comprised of lots of small areas that have similar characteristics, such as previous hospital admission rates, their age structure, the amount of financial poverty and hardship, socioeconomic factors in that area, to make like-for-like comparisons. At the time of the pilot, we had asked for the data, in fact, just before the pilot, to look at the effects of tiers on hospitalisation, the different tiers of restriction. So there was a live conversation asking for small area data to do this kind of best practice analysis, to show what we eventually showed, that the Liverpool pilot reduced hospitalisation initially by around 43%, with a big push from the military, and overall by 25%. It was an important finding, but we did not receive the data to make that finding until the 22nd of July 2021. There were, I think, 61 emails sent in trying to get hold of the data.
Thank you. So the statistics you've just given of the 43% reduction in hospitalisation, you were only able to properly quantify that after you had access to the data in July 2021, some 8 months after the pilot.
That is correct.
Who was responsible for the blockage in getting you the data? Or what was responsible?
I think systems, a lack of clear line of sight between different agencies controlling the data of what to do in a pandemic situation. If you need to get the right data to the right people at the right time to make the right decisions, you need to have rehearsed what the process is for releasing the data. At the time, the people with the contextual knowledge to provide the best analysis of the data were analysing the Liverpool pilot. So this is a local team needing national data. There wasn't a protocol in place to flow the data in that way. So I think it's a system failure.
Every module data rears its head,
Yes.
I'm afraid.
Now, you've mentioned the 61 emails. We're going to hear from Matthew Gould tomorrow, but I think he was one of those individuals from NHSX that you were liaising with. We can ask him tomorrow about the efforts he took and who he spoke to try and resolve the blockage. But could you just give a summary of the input of Mr. Gould, please?
Yes, NHSX were very helpful in enabling us to put together the combined intelligence system that underpins some important work in the Liverpool pilot and really helped to get different agencies to release the data. The data actually eventually came via a system we had in place, the place-based longitudinal data resource.
Thank you.
But there was a lot of support from NHSX to move things along.
Can we then look, please, at, I think, a graph that shows the modelling and assumptions you made with the data you had, and then the update when you had the complete picture? Could we look at page 9, please, of your statement, which is paragraph, the top of the page, please, if that could be expanded. This is the impact of mass testing on the hospitalisations. We can see the 43% figure. Is the smaller figure, the 25%, is that the initial assessment that had been made without full access to the data as to what it was thought in November 2020, but its success of the pilot?
No, the 25% is the main figure. That's for the whole period when Liverpool was testing and other places weren't with lateral flow devices. There's about a quarter reduction in hospitalisation. That's the main headline. In the first few weeks with military assistance, there was a bigger effect, and that's the 43% number. We weren't able to show any effect at the time because we only had data aggregated for the rest of England to the level of local authority districts or hospital catchment areas. The Joint Biosecurity Centre at the time had the lead on that analysis on hospitalisation, so they weren't able to get those national data.
So can I just pause you there? So after the pilot had finished in the November 2020, the Joint Biosecurity Centre also was seeking to try and get access to the hospitalisation data.
Yes.
Were they able to say what the difficulties they had? Did they assist as to where the problem was?
They didn't specify.
No. And so I jumped ahead of myself. So actually, by the end of the pilot, you could not make any assessment about what impact the pilot had had on hospitalisations. You were only able to do that in the July, once you had the data.
That is correct.
And so can I then ask you what conclusions you were able to draw at the end of the pilot about its successes, please? And perhaps in doing so, give a summary of what was happening practically with the people of Liverpool, please.
By the 10th of December 2020, we were able to report back to SAGE an increase in ability to detect cases. We were finding people who didn't have symptoms and were testing positive. Our ability...
Yeah, testing positive on the lateral flow.
Yes.
Thank you.
So the testing positive on lateral flow, that increased our ability to detect cases by around a fifth. We estimated a reduction in cases by around a fifth. Communities very much welcomed. There was very positive feedback. Communities said this gave them hope. The call to arms to our communities was, let's all get tested. That then moved to test before you go. And a quarter of a city came forward in a month. This is the November rain. There was a lot of negativity in the media at the time around the value of lateral flow devices. So with a grit and grace that is distinctly Liverpool, our communities came forward.
Can I ask you, what is the figure of a quarter of the population of Liverpool, just to have some idea as to the sign-up by the community, please?
Yes. So there's a 500,000 population of Liverpool in total. Throughout the whole pilot, half of the city came forward. It was that first month with the critical findings that we had a quarter of the population volunteer.
Thank you. And can I ask you, you reference in your statement the issue of culture, and you say that despite the health challenges faced by the City of Liverpool, the decades that you've detailed of rising poverty and ill health, the culture of Liverpool is highly collaborative and welcomes participation in research and data sharing to advance health. Can I actually then, extracting themes, given the importance of public engagement in public health initiatives to combat pandemics, and in test, trace, isolate in particular, why do you think this is, and how can such a culture be promoted throughout the United Kingdom?
Throughout the United Kingdom, we have the benefit of local public health teams. One of the most important roles of those teams in protecting and promoting human health is to develop a relationship with communities, to understand the contexts in which people live. So when there is an urgent situation, like a pandemic, those relationships don't have to be created overnight, and they can't be created overnight. They're drawn upon. In the Liverpool pilot, we were able to access community leaders to shape the forms of communication that went out from Liverpool City Council. The key messages, even the hashtag Let's All Get Tested, was road tested with our communities. The feedback from those attending testing centres, critical feedback such as we may not isolate because we may not be able to afford to, was vital insights, afraid of losing income or losing jobs. This is in a city where 48% of the economy relies upon visitors. A third of children are still born in poverty. As a public health physician, I think about harms not just in a week or a month, but over a whole lifetime. And the life chances of children growing up in the pandemic were an important consideration. That was expressed by our communities as well. They really cared about that, and they wanted to understand the role of testing.
Can I just, whilst you've just mentioned children, can I ask you around, from a public health perspective, we have statements around education and testing, but have you any views on who are key locally for getting testing right in schools, please?
Director of Public Health, the existing relationships between schools, health activities that happen all the time in good public health practice between schools and local public health teams are vital. In fact, in the Liverpool pilot, many of our schools wanted to involve their children and their families in creative means of engagement in testing. Ideally, there would have been that kind of approach, not driven from the centre, but really using that local resource. Considering parents, grandparents, extended family, you don't test a school in isolation, you test a community. And a school is a really important part of that community. It's a hub of information and coordination.
Thank you. I'm going to look with you, please, the summary you've given in paragraph 19 of your statement, if that could be displayed as to findings. But just on the practicalities, we know that lateral flow devices were being utilised. If someone tested positive on a lateral flow device, is it correct that the pilot then was to provide a PCR test to then check if that was supporting the positivity as identified on the lateral flow device?
Yes.
And,
yes,
and
that is
that's
true.
what fed into the ability to say the lateral flow devices are effective and they're usable from a mass perspective. Or perhaps if you want to give your evidence about that rather than me summarising it very poorly.
There were two ways of looking at the effect of lateral flow tests. One was just the quality assurance. So a subset of the people coming forward had two swabs, one for the lateral flow device, one for PCR. And that looked at the core quality assurance. That's the number that comes forward of the 40% sensitivity, which is what we expected. So that told us the device was working as expected. On the confirmatory PCR, if someone tested positive and faced potential challenges of loss of income from work, it was felt important to do a confirmatory PCR test. We used local messaging rather than relying on a national follow-up for PCR, and that worked very well. If you receive a text message from your general practice as normal, and you extend that to say, you've tested positive on lateral flow, do you want a confirmatory PCR? If it's a local message, people are more likely to respond to it than something they're not used to.
Can I ask you about that? So was that the mechanism of giving the communication through GP text?
That was developed partway through. So this is part of this evolution. It's the importance of an action research response, considering how you can improve an intervention in flight.
Thank you. Well, let's look at your paragraph 19, please, which summarises the main findings from the pilot. Firstly, as you've already said, testing had public support as evidenced by a quarter of Liverpool's population volunteering to test in a month, despite that media speculation. Secondly, testing increased detection of previously unknown cases. Thirdly, the Liverpool pilot reduced the number of new cases by around a fifth. Fourthly, poverty, low digital access or poor literacy were risk factors for infection and barriers to uptake of testing. And fifthly, fear of income loss drove reluctance to test, indicating a need for financial support for those on low incomes testing positive and having to isolate. And then you say this, which I'd like your help with, please, Professor Buchan. All but the fifth main finding were acted upon. Can you be clear what you mean by that, please?
Yes, the fourth finding showed that those in digital poverty were more likely to get COVID and less likely to get tested. So we advised a universal access approach, not requiring a website or an app to access testing. And some of the communities we serve, we target a reading age of 9 to 10. And there's low health literacy in some of our communities in greatest need. So universal access, picking up tests from a pharmacy, etc., without needing a digital means was really important. That was accepted. Arguably even more important was support for people to isolate without fear of losing so much income it would imperil their family or risk them losing their job. And that wasn't acted upon.
Can I ask you, because we know at this time in November, the scheme in England that gave a £500 isolation payment availability was in place. Did you see any effects of that operating in practice in Liverpool in November time?
No, it was too complicated. It was an unusual scheme. There was a local variant of that. We asked for more resource into local variants to engage, to use our local communication systems to explain to communities and make it easier to access payments, but that wasn't forthcoming. Ideally, these things would be prepared before a pandemic.
Thank you. And then can I ask you on the general theme, do you agree that proper levels of financial support for isolation must form part of preparedness for a future pandemic?
Certainly.
Your recommendations, which we'll come to in a moment, include access to support for those who may struggle in isolation. What features do you consider such a system of support should offer to workers, please?
Financial support, material support, if childcare is needed. Work with communities to find out through scenarios what support would be needed in the case of having to isolate tomorrow. These things can be rehearsed now.
Thank you. Now then, on data sharing as well, you've already mentioned about the public support. You detail in your statement that public support is vital for data sharing needed to optimise pandemic testing, and that there's been strong public support for data-driven health innovation. Can you offer any observations on what steps should or could be taken now to maintain public support for and confidence in such data sharing?
Yes, for example, Liverpool City Region created the first civic data cooperative to make data of local residents work harder for and with local residents, going through scenarios of how to protect and improve health with data-driven technologies. In each of the workshops I've had the privilege of serving those communities in, there have been remarkably helpful and creative ideas that have come forward from residents. We've just run a residents' assembly on uses of data for Liverpool City Region with around 80 participants. And there's a really strong feeling that there needs to be feedback. If the public has said we expect data to be used in a particular way, our communities want to be kept involved, want to be in the loop. And so we've seen a remarkable public support for the kinds of data flows that we need in extremis in pandemic responses.
Thank you. And can I ask you again, in the context of that, how are issues or concerns around privacy and security overcome in that scenario, please?
By applying best practice information governance, the CIPHER system was rolled out with best practice security. For example, our data analysts don't need to see names, addresses, anything identifiable, but they still treat the data as if they were identifiable and work in trustworthy research environments or secure data environments. That discipline was in place because we'd been preparing the Civic Data Cooperative, which also includes cooperative working between universities, local public health teams, the National Health Service, using one system. So core information systems that are well governed. It's easier to have good governance on one system than to have three parallel systems where you're diluting your resource for that governance, for separate systems, for direct care, research, and planning separately. Combined approach was very effective.
Thank you. Now, you tell us in the statement that on a rolling basis, as the pilot was taking place in Liverpool, you were updating the findings to SAGE. Is that correct?
That is correct, yeah.
And can I ask you then whether you've any observations or you've any knowledge around a pilot that was also being run from the 21st of November to the 20th of December 2020 in Wales in Merthyr Tydfil? Do you have any knowledge about the final workings of that pilot as to whether they similarly were sharing the findings of their pilot with SAGE?
Yes, colleagues in the 8th Engineer Brigade were preparing to mobilise into Merthyr Tydfil from Liverpool. So this was discussed in the after-action review meetings, the mop-up meetings with the military, what they'd learned from Liverpool, and how they were going to deploy in Merthyr Tydfil. Indeed, one of my departments was deployed into the Welsh Government. One of my department from the University of Liverpool was deployed into the Welsh Government as a health economist and worked on the evaluation of Merthyr Tydfil pilot. We deliberately kept the evaluations independent, as that is best practice.
Okay. And so is there any other additional insights you can provide relating to that pilot?
Yes, the economic evaluation showed that there was a 10 times return on investment. It was modelled that there was a 10 times return on investment. I think the eminent statistician George Box said all models are wrong, but some are useful. I believe this one was useful and thoughtful, i.e. the cost of testing, 10 times that amount was saved. The public participation was very high. The community benefit was tangible. Community involvement was best practice.
Thank you. And then, again, through a Welsh perspective, we know from your statement that asymptomatic community testing in the wider Liverpool region began on the 3rd of December 2020, essentially a month earlier than under the scheme that was launched under the community testing programme. But then, similarly, or differently rather, in the Welsh Government on the 28th of January 2021, they essentially targeted community testing in Wales, firstly only in 3 local authorities from the 3rd of March 2021. And are you able to assist as to why a different approach was taken as to rollout of that testing in Wales when your pilot had identified the clear benefits of testing and identification of positivity with asymptomatic presentation?
I think there were a number of factors. Throughout England and Wales, there was discussion at the time as to whether asymptomatic testing sites, rather than self-testing, were the predominant means of delivery and conversations with local authorities, local public health teams, about the variety of ways in which that would be deployed, it became more apparent that the most powerful means of protecting communities was to give those communities the lateral flow test, the tools to use in their own homes, to fit into the rhythms of daily life and to self-organize around. There was another factor in Wales. I think there were elections at the time, so there was reluctance to commit finances for a long period.
Thank you. Now, can I ask you, when you've talked about the findings you'd identified as to digital poverty, can you help us to which policymakers you presented those findings to and any response you received to those findings, please?
Yes, I presented the findings on digital poverty first on the 10th of December 2020 to a SAGE meeting chaired by Lord Patrick Vallance. We were questioned in detail about that particular finding, and it was accepted then in the formation of a community testing policy that there should be access to testing without digital means. The full community testing rollout came into play eventually in April 2021. There was time needed, I think, to ramp up the logistics, the supply of the testing, and for local teams to get used to the previous conversation, changing from testing sites and specialist methods of testing, in a way, testing that was done to people, to testing that was done with and for people, which is by far the most powerful means of protecting a community if they really understand and can embrace those tools and use them to best effect.
Thank you. And can I ask you then a thought around what else can be done? How do you think public health systems can better address digital exclusion, particularly for ethnic minority communities in future public health crises?
We're moving to an age where AIs can speak different languages. It would be normal for an NHS AI at some point to ring you up and say, you've got an appointment coming up. How are your symptoms? How are you getting on with those medicines? As it becomes normal to interact with services through AI, we can lower the barrier to information. We currently rely on technologies that you have to read and type into. When it's talking to an AI and it listening to you, there is more calibration you can do with the end user. There's a way of improving the access to the information that flexes to the needs of the person being interacted with.
But how does that lower the barrier for those who are digitally excluded?
That's a very good point, my lady. Some of my communities can't afford a data tariff, so we need digital inclusion across society for many purposes that would benefit us in pandemic times. The basic technologies are there. The affordability is another policy question.
And by that, are we talking about giving people devices? Because if they've not had a device before, the chances are they're not going to be very adept at using them, are they?
No, I think policies to give access to connection is the most important way forward. There are many groups, in fact, in my own university, Professor Simeon Yates and others study digital inclusion and the means of different policy options for bringing people in to an AI age where it will be very difficult to interact with services without being online. But if I look at India at the moment, you can't have a bank account in India without talking to an AI. Sometimes the devices are shared between families. You can't prescribe what people should use. But I think we can, in public health and wider policy making, assist the connection of those devices to a wider world of service and information.
Can't provide an 8-year-old grandchild to rely on either, can you, to everybody?
Thank you. I'm going to move now to recommendations for the last portion of my questioning, please. I'm going to display only very briefly so it underlines the point you wish to make. Please could we display INQ 587458, which is the structure of the various SAGE subgroups that provided the advice that fed into and assisted decision makers. And we can see Scientific Pandemic Insights Group on behaviours, SPI-B, and then the Scientific Pandemic Insights Group on modelling. But I think you have an overarching recommendation that you would wish to make in respect of a different sort of group that's needed. And I think, is it fair to say, looking at your statement involving public health but taking a systems approach? And could I ask you then to give your suggestion to her ladyship, please?
As my colleagues in SAGE have already cited, a systems approach is vital. Public health practitioners implement science in a systems way, but public health researchers also create a joined-up scientific conversation. For example, members of SPI-M contacted my colleagues and were surprised to find out when they were modelling the spread of the COVID-19 virus between hospitals and care homes. They were surprised to find that staff in care homes work between different care homes in the community. Some of those staff, which are some of our lowest paid workers, live in close-knit communities themselves. So the routes of transmission, this is second nature to public health researchers such as myself, who are regularly asked to look at complex patterns such as these in local data, giving those modelers the heads up that they should build their models differently could save time. Now, that is a behavioral insight from frontline public health practice. Similarly, I have researchers who do joint modeling of behaviors and the spread of a virus in a pandemic. That's very useful for behavioral scientists to know about the latest mathematical advances as they pertain to a pandemic situation or other public health means. So public health is the glue. Public health research can glue together better science. It creates a continuous learning system, a rapid learning system, which is vital for pandemic responsiveness and preparedness. A SPI-S, so systems input here, could be runners between these different groups who come together as public health researchers, like bees cross-pollinating the flowers and making sure that there is a joined-up conversation as early and as deep as it should be. And perhaps a little more representation of public health research on the regular membership of SAGE to put that joined-up conversation back.
Thank you. And in fact, Professor McKee himself also referenced the essential nature of the glue of public health. And it's clear from what you've just said, you echo and support that principle.
I do.
For pandemics preparedness.
Can I just ask, is it necessary to have a new group, or could you have better representation? You've said about on the main membership of SAGE, but what about public health researchers on SPI-MO and SPI-B?
You could have a distributed group like that, runners who are members on those other groups. We have a good line of reporting from directors of public health to our chief medical officer, who does an excellent job of integrating those views. But the public health research, it does need embedding in those research conversations very, very early. And some of the research would be done differently if you've got that embedded view.
So you're saying that's why you need a specific group as opposed to simply scattering public health researchers across committees, subgroups?
I think the people across the subgroups need to talk to one another to compare notes.
Thank you. And then for ease of summary and also because of the timings. Can I have display, please, page 21 of your statement, where you've very comprehensively summarised your recommendations. The wider statement will be published, Professor Buchan, but your overarching recommendations alongside what you've just said around a SPI system is, firstly, that UKHSA to maintain and disseminate a blueprint for purpose and data-driven pandemic testing, building on the work that you've detailed in the statement, but essentially with a clear clarity as to purpose as to why you're testing, and you've given all the various variations of how you use the tool of a test and the need to know why you're doing a test. Would that be a fair summary?
It's vital to be clear about the purpose of testing. We've seen that the optimal medical test for COVID-19 is not the optimal test of infectiousness for carrying the virus of COVID-19 and potentially passing it on. A test that takes 2 days as a medical test, 2 days when someone could be passing on the virus and otherwise be informed by a rapid test that they should isolate to protect their community, to use differently, to come back to work soon. A test to release from isolation has another need. It's when you become negative. We saw in 2021, the UK had many posts on social media about people's repeat lateral flow tests. And when that blue line went fainter, that was them losing infectiousness. At the same time, the United States in Omicron was saying go back to work after 5 days.
Thank you.
We were able to show actually people were infectious beyond 5 days. So the clarity of purpose is really important for how you design the testing program.
Thank you. And you've set them all out there. Similarly, Professor Buchan, we've not had time to deal with, but it's detailed in your statement that will be published, how the lateral flow devices were used for test to release with the blue light service and frontline workers. And then if we go over the page, please, we can see the continuations of test to confirm and test to understand. But then the second recommendation is for UKHSA to use the pandemic testing blueprint to run scenario planning activities and develop, maintain and publish sleeper protocols. It's detailed there as to your support for that, but I think building on what you said about data, would you also be recommending essentially work is done now on developing protocols to essentially get over the issues of data that have caused blockages in the pandemic, as I've seen in the evidence that's been before her ladyship?
I would. I'd urge Operation Pegasus and other activities of preparedness to look very deeply at the complexity of systems of response that need to be evaluated as whole systems. For example, with lateral flow testing, one person testing in a family can affect another person's risk behaviors. They may be more cautious, they may adhere to guidance more if there's raised awareness in the family. So the way you evaluate that needs to consider the whole complexity of that intervention. It is more than a test to break one transmission chain of a virus. It is a community intervention and needs analysis from the biological, the behavioral, the environmental, social perspectives, a multidisciplinary evaluation. The protocols for that will highlight the different data sources that need to be brought together. The granularity of those data, we mentioned earlier, we needed neighborhood statistics on hospitalization.
Thank you.
So having those prepared now is entirely possible and will be extremely useful for the next pandemic.
Thank you. You've given a number of headers as to what those protocols should address. But finally, please, for my questions over the page, you also make a recommendation, again with underpinning detail, which we won't have time to explore, but essentially that all stakeholders to test and refine the principles, plans and protocols through continuous preparation between pandemics.
Yes, we have a rehearsal most winters with winter pressures. And the data systems we need to respond to winter pressures are the core information systems we need to respond well to the next pandemic. So the investment in those, which isn't just financial investment, it's the investment of talented teams in each civic setting, in each academic health system. Many places where engineers, scientists, people in the NHS, local public health teams can come together and develop ideal information systems for health, particularly as we've got highly advancing AI potential. To do so can create jobs in a local community, which many of our residents who take part in exercises of how they want their data to be used say is really important to them. A national grid of this kind of creativity also provides that distributed resilience. There's communities who not only are inputting the right data at the right time, but they know how to use the output intelligence from those systems. If we're applying that to responding to winter pressures, for example, we're rehearsing for a pandemic.
Thank you, Professor Buchan. Those are my questions. My lady, there are a number of core participants who've been granted permission to ask questions.
Mr. Jacobs, he's over there.
My lady, my questions around the effectiveness of the test and trace support scheme, and I think, in fact, that's been covered. So I'll leave
Thank you
it there.
very much, Mr. Jacobs.
I'm grateful, thank you.
Thank you. Mr. Thomas, who's there.
Good morning, Professor Buchan. My name's Leslie Thomas, and I'm representing the Federation of Ethnic Minority Healthcare Workers Organisations. Professor, the matter that we wish to address today is central to my client's concerns and relates directly to the core objectives of this inquiry, the issue of equity in the implementation of the COVID-19 testing strategies, and of critical importance is whether there was proper consideration of the disproportionate impact of the pandemic on minority ethnic communities. And I suppose the concern can be put in this way: whether inequalities and the digital exclusion that disproportionately affected minority ethnic groups and individuals with protected characteristics were adequately considered during the development and rollout of the testing strategies. So with that in mind, can I turn to the questions? And the first question is this: was an equality impact assessment, an EIA, ever conducted on testing decisions that you were part of?
Thank you, Mr. Thomas. Yes. The equality and the equity impact was core to the design of the Liverpool pilot. We broke down our dashboards that all of our organisations looked at on a daily basis by ethnicity, material deprivation. In fact, we noted that a greater proportion of people attending testing centres were refusing to declare ethnicity. So we talked to local community leaders about feelings on that. It was very much a conversation, not just consideration of the data after the fact. We also went to community leaders and put before them potential publicity material, the Let's All Get Tested campaign, the Test Before You Go campaign. Indeed, we'd had remarkable success in Toxteth with more conventional testing in summer of 2020, led by community leaders employing unusual devices like an ice cream van, involvement of local faith groups, really shaped by communities. And this is very much a Liverpool way of doing things. So our recommendations to national policy were to use those relationships of local public health teams with their communities and be prepared to flex.
With that last answer in mind, what were the outcomes and how did those findings of the EIA influence the development and the rollout of the testing strategies?
I think the universal access testing strategy accepted our impact assessment that financial and digital poverty, but other forms of barrier to access to testing were really important considerations, and that they had to listen to local public health teams through the Association of the Directors of Public Health, through the reporting lines to the Chief Medical Officer, on other forms of inequality. We saw increasing inequalities, sadly, throughout the COVID-19 pandemic. So this is front of mind in my public health colleagues, and we're grateful to the engagement of our communities.
Finally, this. Given the acknowledgements that you made earlier on, looking forward and being future orientated, what more do you think could be done in the next pandemic?
I think there's a planning meeting tomorrow for some of the preparedness of Pegasus in the autumn. Whatever we do now to consider future pandemic responses needs to consider equity at its core. And the measures for preparedness need to be co-created with a sufficient diversity of people of lived experience of being asked to isolate and the consequences of that, being asked to use tests in ways that may not be accessible. We can overcome those barriers if we have an inclusive approach to the rehearsals underway.
Thank you, Professor Mulady.
Thank you, Mr. Thomas. Ms. Munro.
Thank you, my lady. Good morning, Professor. My name is Alison Munro. I represent the group COVID Bereaved Families for Justice UK. Thank you very much for your very clear evidence this morning. Just a few points arising, if I may, please. Just two short topics. My first question arises from the Liverpool pilot, Professor. Ms. Cartwright, King's Counsel, very helpfully has taken you through the findings 1 to 5 at paragraph 19 of your statement, and the fact that all but number 5 were actioned. So I'm not going to go through those again. You did also this morning reference a paper that you were co-author to in the BMJ. I believe that was in February 2021, a paper called Put to the Test Use of Rapid Testing Technologies for COVID-19, is that right? Under the subheading of Test to Release in the paper, you say this, or you and your co-authors say this: no test can replace comprehensive support, both practical and financial, as a means of tackling low rates of self-isolation, particularly in disadvantaged communities. My question is this. Professor, were you aware that your findings on the need for financial support were consistent with the views expressed by SAGE, Independent SAGE, the AMS and others about the importance of this factor in implementing an effective TTI system?
Yes, this concern was widely discussed amongst my public health colleagues and scientifically public health research colleagues. Was a concern, and so we looked very closely at the data that was coming through from the Liverpool pilot, and we also asked very detailed questions, people attending testing centres and household surveys that homed in on the barriers to isolation.
And I suppose, my lady, if I may just ask a follow-up from that, would you agree, Professor, then at the time there was this growing body of findings from various agencies then about the fact that practical and financial support is inextricably linked to an effective TTI system. And that information, those findings, the government could have drawn upon them if they had so wished, because it was out there at the time.
It was an expected finding. There were plenty of prior evidence that this would be an important barrier. In fact, my colleagues in Wales describe the inverse testing law, as we often describe in public health the inverse care law, that those with the most need for care often have the greatest barriers to care and the lowest uptake of care. We did not want that to be the case with testing. So this isn't it wasn't a surprise.
Thank you very much. Next topic and question. You note at your paragraph 24 that the need to consider local public health complexities was seen in the outcomes of initiatives to increase vaccine uptake, and comment that findings of unsuccessful initiatives were rarely publicised but discussed in forums such as the ADPH. First question, do your observations about the need to consider local public health complexities apply equally to TTI, given the importance, and it's certainly come out from your evidence this morning, of local knowledge, public health experts, and the effectiveness of a test and trace initiatives?
Yes, we used local tracing. In fact, many public health teams across the country benefited from highly local approaches to contact tracing. In fact, in reopening mass events with a public health safety net in place, we focused on not just testing before attending an event, but vigorous contact tracing for anyone who tested positive, and communication to minimize mixing before and after the event. That local approach is highly effective when you're responding to continuous feedback from your communities on what is understood, what is expected, what the concerns are. And I would encourage that local approach in future, even in designing artificial intelligence that allows greater scale in contact tracing. There aren't enough people to go around to follow up everyone at the height of a pandemic. We'll have to use technologies, but they can be designed by local communities to fit the way they speak about life in general, about the concerns that they have, the language that's used, and how that adapts to the feedback they give is really important. We can put that in some of the preparedness rehearsals that we're doing now.
Thank you very much. Finally, again from your paragraph 24, do you think that would greater transparency about unsuccessful as well as successful public health initiatives be of assistance for future pandemic preparedness and planning?
Yes, and I think that message should go to scientific journals on what they accept. Negative findings are extremely important, and there is a reluctance of some scientific colleagues to publish negative findings because they are hard to get into journals. In the Liverpool pilot, we deliberately put out findings on a university website. As we had ratified them, we had teams working blind from one another, analysing the same data, answering the same question. And when we ratified their findings, we put that out there before waiting for the publication. There were important negatives. Let me give you an example of the use of vaccine buses. So we saw in Liverpool an increase by 25% of uptake of vaccination with a combination of a bus that went into areas with low vaccine uptake, but with a wraparound communication that was designed by those communities. In other parts of the country, I think Greater Manchester used the bus, but without the wraparound communication. There wasn't that uptake, but there isn't a scientific paper I was able to find on the publication of that. We did publish something from Liverpool. If it had been a negative finding, it might have been more difficult to get into a journal. We would have kept pressing. But negative findings teach you a lot. And the more we have natural experiments, many different local public health teams tried different ways to improve uptake of testing and vaccination. They used different data sources. That compare and contrast is extremely valuable learning. Indeed, I think there's a social responsibility to surface the natural experiments that happen in a pandemic situation.
Thank you very much, Professor. My lady, thank you very much.
Thank you, Ms Munro. Those are all the questions we have for you, Professor. I can't speak on behalf of the people of Liverpool, but I'm sure they wish me to. Thank you so much for all that you try to do to protect them and, of course, protect the rest of the public of the United Kingdom. So, were you born and bred in Liverpool? You're very proud of Liverpool.
I was. I was born in Norris Green in
I've
1967.
got a number of Liverpudlian friends. I thought I detected, I think it was the phrase you used, was it grim and grace? I think I'm
Grit and grace.
Grit and grace.
A gritty
Grit and
community.
How could I say grim? Thank you very much indeed for your help to the inquiry as well.
My pleasure. Thank
I
you.
shall return at 25:02.
Thank you.
All right. Ms Cartwright.
Thank you, my lady. The gentleman in the witness box is Mr. Garton. Could I ask, please, for him to be sworn?
I do solemnly,
I do solemnly,
sincerely and truly
sincerely and truly
declare and affirm
declare and affirm
that the evidence I shall give
that the evidence I shall give
shall be the truth,
shall be the truth,
the whole truth,
and nothing but the truth.
and nothing but the truth.
I hope we haven't kept you waiting, Mr Garton.
You certainly have not. No, not at all.
Could you please tell the inquiry your full name?
Yep, my name is Will Garton.
Thank you. Mr. Garton, can we identify your witness statement, please? And at the outset, it's clear it is a corporate witness statement. It's 98 pages long, and we see your signature on page 98, the statement dated the 25th of April 2025. And can I ask you, are the contents of that statement true to the best of your knowledge and belief?
They are.
Thank you. Can we then identify who you are and the department for whom you work? Because plainly, this highly detailed statement has been the product of a huge amount of work, and it will be published. But I hope, with your assistance, to touch upon a number of issues, and particularly issues that have been raised of concern on behalf of the core participants. So can we commence, first of all, then, with identifying who you are? It's right, isn't it, that you are the Director General for Local Government, Growth and Communities, and you've been in this post since January of 2025.
That's correct.
Although, as you've told us, you had been a Director General in the department since March 2022.
That's correct.
And you tell us that you've been responsible for the department's COVID-19 inquiry unit since January 2025.
That's correct.
And the department is now known as the Ministry of Housing, Communities and Local Government.
Correct.
And you tell us in the witness statement how it's resorted to its earlier name, but just for completeness, because we may see it on some of the documents, can you just confirm how the department was known at the time of the pandemic, please?
Yep, throughout the pandemic, the department was named the Department for Levelling Up Housing and Communities.
Thank you. And plainly, the inquiry's already had much evidence from the department. Mr. Garton, it's right, isn't it, as well as the statement that will be published, what the department has done equally is you have collated as appendices to the statement reports as by way of lessons learning, but also the recommendations that the department have already identified since the pandemic.
That's correct.
My lady, with your permission, those appendices also will be helpful to be uploaded.
Thank you.
Thank you. Now, Mr. Garton, I hope to touch upon a number of issues with you, and necessarily with the short time we have together today, there will be a top line, but in the knowledge that the very detailed statement sits below it. The topics I'd like to deal with you are, firstly, the department's conduit role with local government, including challenges with data. Secondly, the issue of self-isolation, including the test and trace support payment scheme and non-financial support. The issue of disproportionately impact groups. The issue of centralisation of the TTI system. And we may touch upon the department's role in the community testing programme, but I finally will deal with recommendations with you. And so can we start then, please, with the department, but as also its conduit role with local government. And it's clear from a number of the statements we've received, there are lines of responsibility and oversight. And so can I ask you, please, to explain the relevant role that the department had by reference to matters of test, trace, isolate, please?
Of course, thank you. And I think it is helpful to set it out. So the department is the lead government department for a range of different policy issues: housing, planning, rough sleeping, homelessness. Included in those is the stewardship of the local government system as a whole. So it is responsible for the system, for ensuring that it is adequately financed and that it works. Individual government departments have lead responsibilities for issues which are delivered through local authorities. So a simple example of that would be the Department for the Environment, Food and Rural Affairs has responsibility nationally for waste and recycling, but it is often done by local authorities. So we are not the lead government department in all instances. Sometimes we have lead government department responsibility, but the policy is also delivered through local authorities. So an example of that would be planning or rough sleeping, where we are responsible centrally, but local authorities do it. So we're responsible for the system, but not always the policy delivery, if that makes sense.
Yes. And it seems with making that point, on many occasions, the policy decisions, would it be fair to say, would then sit within the local authority and local government?
Yes, so to give you an issue pertaining to children's services, the Department for Education holds policy nationally, and operational decisions are made by local authorities, but MHCLG doesn't necessarily have a role in that conversation per se.
And the inquiry's already heard evidence around the role of the Associate Directors of Public Health,
Yep.
and particularly the role that they would have on things like local contact tracing, which is obviously a role that sits within local government and local authorities. Can you just assist us to the role that the department has then in respect of that function of the local authority, please?
So directors of public health would have and do have a direct relationship with the Department for Health and Social Care, because that is the lead government policy line that runs through. Insofar as the Ministry for Housing, Communities and Local Government wants that relationship to go well, it's a sponsor department for the sector. If there are problems, we can play a role in unblocking them. We may be in the room. I don't think we necessarily always need to be in the room, and I think it is a sign of central government, a mature relationship between central government and local government, that those relationships between, for example, in your example, directors of public health and the Department for Health and Social Care exist directly. We're not some sort of gatekeeper, and nor should we seek to be so, in my view.
But I think you've identified in answering that the role essentially that the department does have for the proper funding of the functions of local government. Thank you. And I think we'll come on to look at that in the context of the isolation support scheme that was put in place.
Yep.
As part of the later period near to the end of 2020, but perhaps in terms of the role that your department had linked to that isolation payment, that was essentially a scheme that was then operated within local government and locally. Can you just be clear about the role that the department had by reference to that important isolation scheme as it operated in England?
Yes, this is self-isolation payments.
That's correct.
So this is their policy responsibility here is with the Department for Health and Social Care. I think on this one we worked pretty closely with both the lead government department and local authorities to try and devise a scheme that worked. That was because it was somewhat novel. We didn't have an established mechanism of doing self-isolation payments to individuals that qualified for them. There are a number of operational considerations about how you make such a scheme work, how you mitigate fraud risk, and how you ensure that the scheme is an overall success. So the accountability and the policy lead sits with the Department for Health and Social Care. On that particular scheme, we were we were quite involved because we were concerned that we could make it work, and we wanted to play that conduit role between local authorities and the Department for Health and Social Care.
Thank you. And then can I ask you, because we know and we've got details already from His Majesty's Treasury around the funding and the aspect that went to that, but the inquiries also has evidence that the schemes as they operated across the devolved nations differed on the issue of isolation payments across the devolved nations. And can you give any oversight or view from the department as to the further complexities when you have schemes that are different across the devolved nations, or whether you can only comment on as it applied to England?
So our responsibility, I'm afraid, only applies to that worked in England. I think we've been working with the devolved governments for over 25 years now, so we're in a good operational understanding about the different approaches that are taken in different nations of the United Kingdom. So my understanding is that the test and trace support payments, the complexity was not enhanced. It was made more difficult by the fact there were different systems operating in Scotland and Wales, but those were largely matters for those respective governments.
Thank you. And can we then explore, just as part of topic 1 then, please, areas where essentially the department engages with local government? If it assists, we're at your paragraph 27, please. Page 6. Thank you. You detail within the witness statement that essentially the various components of engagement that exist by way of this conduit role with local government include through the local government regional relationship teams, engagement with local government sector bodies such as the Local Government Association, the Society of Local Authority Chief Executives, engagement channels by way of emails, letters and bulletins. And is that sort of a very high-level summary of the assistance the department provides?
Yes. I mean, I would say there's probably not a day that goes by in my job where I don't engage with the sector as a whole. We draw great richness from the experience that the sector brings us. We have a number of fora by which we do that. Some are formal. You've got some of them here, the R9, various working groups, it's distinct engagement with local authority chief executives, county council networks, district council networks. Some are informal, but the department has the churn, the everyday rhythm of the department is to engage with the sector and have deep relationships, and it's one of the things that benefits us greatly.
No, thank you. And I think if we scroll down, please, on page 7 to paragraph 28, we essentially see that those relationships were crucial to how the department was able to assist during the pandemic. I think you say that you used those pre-established engagement frameworks to engage with and communicate with local government, and it allowed cross-governmental access to local authorities and access by local authority leaders to central government.
That's right.
And can we then please explore an issue as to, I think what you've described a moment ago about how the department could assist where blockages occurred. Mm-hmm. And one of the issues that's identified within the statement, and I'm going to do it as an overview rather than get into the particularities of the detail, is that local government was raising issues around access to data, and particularly data that the Department of Health and Social Care had a role in, that links to the local resilience forum role that local government deploys. So that's many layers of different bodies and organisations. And so perhaps if I break it down, first of all, it's right, isn't it, that the local resilience forums sit within the local authority, and it's multi-agencies that cooperate to the local resilience forums, and particularly in pandemics as part of the Civil Contingencies Act.
So local authorities don't sit within resilience forums don't sit within a local authority. So there are local resilience forums map onto police authorities in England, and I know that you unpack this a bit in Module 1. They were an important part of our response to the pandemic. There are 39 of them in England, and were able to give us an insight in what is happening with places. Actually, I think the most of the engagement on this model is for test, trace and isolate, and some of the issues that have been raised in the witness statements about access to data pertain to the individual local authority. So they're at a smaller geographical scale than the Local Resilience Forum, which will tend to be a group that coordinates the major frontline services, not deal with public health outbreaks in an individual council.
Can we look at it then in a context of a particular paragraph? And thank you for the clarification around the local resilience forums. Could we move, please, to page 29? It's paragraph 125, please. And this is a specific issue that's raised, and you've helpfully set out in your statement by reference to a data issue relating to the test, trace, isolate system. You say this: as the TTI system was established, the department worked with the Department of Health and Social Care to raise the data needs of local authorities. Some local level data was provided to local authorities via the Local Resilience Forum dashboard, as you deal later in the statement.
Yes.
However, you say this, that local authorities frequently escalated concerns to the department around having limited and unreliable access to COVID-19 test and trace data. And so can I ask you to either unpack that
Yep.
or expand as to
Yep.
that issue and how the department assisted and was it able to unpack that issue
Yep.
of access to data, please?
No, of course. I mean, I think this is a significant issue. It comes up obviously in my witness statement and in that of many others. I think it is true to say that at the start of the pandemic, the department received many representations from local authorities about what they perceived to be a lack of any data or data that they could usefully use. My witness statement from paragraphs 125 to 135 gives examples of how the department tried to raise that centrally to try and break through, to try and make progress. And I think what you see over the course of the course of 2020 is an evolving story and an improving story. I think that to start off with, and I think that the Local Government Association recognised that. In March and April, I think local authorities felt that they weren't getting data that could meaningfully assist them. I think by May 2020, the arrival of Tom Riordan as both the Chief Executive of NHS Test and Trace and simultaneously the Chief Executive of Leeds City Council helped matters considerably. A good practice network was set up. Local authorities were on the board. And by about June 2020, the Department for Health is producing an interactive dashboard, as I point out in paragraph 133 of my statement, that whilst not perfect and not doing everything that local authorities would like, is giving number of cases, rolling averages and so on and so forth. But nonetheless, there are limitations.
Can we just look together at paragraph 133 and 134? Because if we look at the context, it seems that what local authorities were saying is the lack of access to this data was fundamentally impeding what local authorities could be doing on the ground in the various local authorities. Now, you've already highlighted on the 6th of June, the Department of Health and Social Care contacted the department to request support in sending a letter to local authority chief executives, local resilience forums and directors of public health to provide details of the new data dashboard to monitor outbreaks in their areas. The dashboard was developed by the Department of Health and Social Care, NHS Digital and NHSX. The letter provided colleagues in local government, directors of public health and clinical commissioning groups, just pausing there, I know it was clinical commissioning groups at that time that they've subsequently gone now and it's ICBs. But
Correct.
So clinical commissioning groups, details on how to access the data dashboard, and then you deal with that letter. And you say this: the dashboard allowed local authorities and directors of public health to view anonymised data, including data on the total number of tests conducted and positive tests, including a rolling average. And then you detail where the data was being combined from NHS Digital's COVID-19 National Testing Programme database, consolidated data covering the national testing programme, and 111999 data about the rate of calls. And if we could just please expand paragraph 134, and you say this: despite the launch of the local authority dashboard, the department raised concerns with the Secretary of State that there were a significant number of gaps in the data which local authorities required in order to respond to the COVID-19 outbreak. And then you go on to detail the work culminating in the advice being sent to the Secretary of State, Mr. Jenrick, who in post at that time, and also on the 24th of June 2020, setting out the additional data requirements of the local tier. And so we can see then in that statement as well that the advice recommended by Mr. Jenrick was escalated to the Secretary of State for the Department of Health and Social Care, Mr. Hancock. And then if we go over the page, please, to paragraph 33, we can see that it details the draft letter included a breakdown of testing data requirements, including requests from directors of public health, RRFs and local authorities. You say a draft version of the letter was shared with the Department of Health and Social Care officials, which resulted in further progress being made. And by the 30th of June 2020, the department had gained access to data around testing, COVID-19 cases and contact tracing at local authority level. And you say that evidence suggests it was Mr. Jenrick also escalated the issue with Mr. Hancock at a ministerial meeting in July, but you have no further evidence of the outcome of that conversation.
That's correct.
And so what I really want your help with, we know that the pandemic was announced in March of 2020. Here we are more than 3 months later, where local authorities, and in particular the directors of public health, who have a key role in respect to responding to the pandemic, were saying that they did not have access to the data that it needed. And can you assist at all in terms of how that could be, but also whether those issues have now been resolved by reference to learning since the pandemic?
Yep. As you have articulated, the department throughout these months was pushing very hard for an improvement in the data sharing going on between central government and local government. I think it did get there, and by July we see a significant improvement, and I think it's a perfectly reasonable question to say, could it and should it have been faster? And Department for Health colleagues, I'm afraid, will explain to you better than I can why it didn't happen faster. I would say, though, that, I mean, as I look through some of the witness statements, sometimes the department for which I work was requesting information from the Department of Health to assist local authorities, and the Department of Health came back to us and said, we just don't have it in that form. We can't do it. So I think sometimes it's easy to perceive, if you're not in the receipt of the data, that just over the fence there is the perfect data set that's ready to be sent over if only someone would press the button. And I suspect, and I don't know because I wasn't in the Department for Health at the time, that was not the case, that it was inaccurate. There were multiple problems in assessing it and getting it together, and therefore it wasn't as simple as, could you just email it over in an accessible format? That said, I think there is a question for us collectively as we look back of, could we have reached that better place in July earlier? And I suspect we could have done, and we could have done better. The second part of your question was, are we now ready?
Yes.
I think in principle there would be a collective understanding in central government that data sharing should happen more quickly, and there should be a higher degree of risk tolerance. I don't think, though, we have yet, although it might be, I understand, something the inquiry might want to look at and recommend, and we would obviously take very seriously. I don't think we yet have protocols in place, principles agreed for how we would want to do it differently. If you'll allow me a general observation, and it is a general observation, so it is flawed like all general observations, but I think we are still quite conservative, small c conservative on data sharing. I think quite often GDPR is the general data as a whole in the public sector, we need to get better at creative ways of making this happen. Some colleagues will have some concerns, data security and the like, all of which will be legitimate, but I think there is more to do in this space.
Thank you. We'll perhaps come back to what appears to be a potential area of recommendation for her ladyship around protocols around data sharing.
Yeah.
Mr. Garton, thank you for that answer, but also the frankness with which the issue is identified in the statement. But appreciating what you say about it wasn't necessarily that the data was sometimes there waiting for someone to press a button, but would you agree from the perspective of interoperability and the areas where the data sat that were particularly important in a pandemic, plainly it involved access to health records, medical records, it involved public health data, personal data that individuals were sharing with the contact tracers. But essentially those pockets of data where they sat to inform planning and systems is completely capable of consideration in peacetime as to development of protocols to ensure that the relevant data controllers can find a solution to data issues and privacy to enable agile interoperability in a pandemic.
I think that's something that is a standard to which we should hold ourselves, and that is not unreasonable at all, that the British state should be able to do. Yes, I think that is something we should aim for. I think we got better. I think it got better. The Contain framework published in July effectively, and you will have a more detailed understanding of this than me, but effectively moved much of the lockdown onto a more localised footing. We got better at localism as the pandemic moved on, but it is the case that in the early months it was a national response.
Yeah. Mr. Garton, thank you. The evidence you've identified linked to protocols chimes with evidence we heard this morning from Professor Buchan, with a very real example of a blockage of data flow that he needed around his project. So it's very helpful, the evidence you've given, but I know you weren't in the room when he gave evidence. Thank you. Can we then just explore an issue, please, linked to a particular document? And I know you appreciated that the issue improved, but could we please display 104738? Thank you. And so if we just orientate ourselves here, this is the advice memo that the Secretary of State sent about the ongoing data issues, about the test and trace data requirements. But could we move, please, to page 4? Thank you. And I think the table acknowledges that the data was needed to understand coverage of different communities, sectors of society to target policy change and engagement activities. Have you had an opportunity to review this as part of preparations?
I have, yes.
And so would that be a broadly fair summary about what the table's identifying here about the data requirements?
Yes, I think it is, and I wasn't in the department at the time, but I think it's a rather helpful table in that it tries to specify in plain English what we need, why, but critically, have we got it? Is it possible? So it's not just wishful thinking, and that enables us to have a more mature conversation about, can we get this fixed?
Thank you. Now, I think this is part of the categories of data that were being requested and pushed for from local authorities. And perhaps you've already touched upon it. The table details that, in respect to some of these categories, the data did not exist, certainly at the time when the document was drafted. Yep. And can you assist? Do you have any views as to what were the implications of this data not being available at the local level at this stage in terms of developing timely interventions that may have been necessary to support particular communities?
I mean, only a general observation, which I don't think is very profound, I'm afraid, but to say that the more information that we all have, the better place that we are to tackle the pandemic, the better position we are in to try and mitigate the impact on disproportionately impacted groups. The more we have, the better.
Thank you. And then just a follow-on question, if you can assist. Are you able to comment at all about what the lack of that data, how that impacted or may have impacted upon your department's ability to support local authorities to understand and respond to trends in their communities?
I don't think it would have affected my department's ability. I think it would have affected the ability of the Department for Health.
Thank you, that's helpful. Now, I'm going to take you to some of the criticisms that that have been identified in witness statements provided by the Local Government Association and the Associate Director of Public Health, Mr. Fell, who's the author of that, and give you an opportunity, if you can assist at all, to comment or provide your perspective of the problem that's identified. Could we please display INQ 587454? And this is the statement, the witness statement of Joanna Killian on behalf of the Local Government Association. And I know this was provided in your pack, and it's paragraph 52. I seek your assistance with if you're able. We can see that within that statement, it's detailed the lack of any individual level data on COVID-19 cases being shared with the Directors of Public Health at the outset made it impossible to support those affected and to control outbreaks. The LGA repeatedly requested this data at meetings and in emails. At various times, the LGA was questioned by Public Health England about what Directors of Public Health would need individual level data. And so Ms. Killian describes the issue as making it impossible to support those affected and control outbreaks. Do you have any observation, or do you share that view?
Joanna Killian obviously speaks for the sector as a whole. I would say that my witness statement contains lots of evidence of the department, the Ministry for Housing, Communities and Local Government also making the case for more data sharing. So I don't know, not really in a position to judge whether that makes the work impossible. I think it certainly makes it more difficult. But yes, MHCLG at the time were all making a similar and related point that we needed to do this more quickly, as evidenced in the witness statement. I don't know the extent to which that was possible, because I don't have sight of the trade-offs and the difficulties that the Department of Health had, and I don't have an accurate picture of what data they were sitting on and how hard or otherwise that was. But I think, irrespective of that, this is something that we should collectively get better at.
Thank you. And again, you may not be able to assist, but we can see one of the blockages here, or the barriers, was Public Health England as it existed then, questioning why the Directors of Public Health needed that level of data. Did that degree of granularity of the blockages get delivered into the department to assist with unpicking those sorts of issues?
I think it's unlikely we would have necessarily done it on a local authority by local authority basis, but as you have highlighted, we were engaged with the Department for Health on the types of data that were missing and why on a consistent basis.
Thank you. With your assistance, please, can we move forward in the witness statement, please, of Ms. Killian to paragraph 59? Thank you. And could it be expanded, please? Ms. Killian details, because of the United Kingdom government's misunderstanding about the role local authorities could play, it also excluded them from any design of any data collection which captured information needed to act on the test result, such as an individual's identity, location and key characteristics. As a result, the data collection forms for testing and tracing were poorly designed for operational use at a local level. The early test and trace data had no unique identifier, ethnicity, postcode, occupation or information on work address or care home address, despite the fact this would be needed for outbreak control. In addition, only positive results were being shared, not negative, making it impossible to tell the positivity rate. Now, obviously this criticism is levelled against central government. I appreciate your department is just a department, as you've already clarified your role, but did you in the department, first of all, have any misunderstanding about the role that local authorities could play?
No, I don't believe we did.
And so it's really a matter for Ms. Killian, who particularly, it's said, in terms of central government. And do you have any detail around the data collection forms that were in operation to be able to comment assist at all about the criticism that's levelled there?
I mean, again, this is, I'm afraid, primarily a data that sat with and was the responsibility of the Department for Health and Social Care.
Thank you.
I would just say, I think we would agree that by July that had been resolved. So the exam question from my mind is, what stops it happening earlier, and was it possible to do it more quickly? So I think this is the LGA's observation at a point in time, and it is something that improved over time.
Thank you. Can we then please move to paragraph 62, please? We again see reference to those collection forms. It details, despite repeated requests to change the collection form to solve some of these problems, officials were not willing to change the form to collect the data, even though it would have helped local response. Was the department, your department, aware of those requests at a local level for amendments, and were these the sorts of issues that were being assisted with by your department to block the blockages?
Yeah, I can't speak to the precise reference made in paragraph 62. What I can say is, as we set out in the witness statement, that the kind of issues that the LGA were raising were the issues that the department was also raising in order to try and get it resolved. So that is consistent.
Thank you. Now, you've already helpfully suggested a potential area where there could be work done in peacetime around data protocols, but can I ask you whether this still is an issue as identified in paragraph 62? Ms. Killian goes on to say that there'd been general reluctance by government to routinely share individual test and trace data with local councils. And she goes on to say that valuable time and effort was expended by local directors of public health in trying to access data that would enable them to respond better. Do you know whether any individual work's been done around that support for directors of public health since the pandemic on that issue that's identified by Ms. Killian?
So I'm not aware if the Department of Health and Social Care have done more work on this since. I think, as the inquiry knows, the government as a whole is intending to run a pandemic preparedness exercise this autumn. I would suggest that this would be one of the key things that we should look to test as part of that process to understand whether or not how improvements can be made. I think there are, since then, other examples of central government getting better at data sharing with local authorities. I do not think we have a complete picture. I do not think problem solved, that's now fixed.
And thank you for that frankness, because as you're well aware, Milady is looking and considering as part of this module in particular about any recommendations that may assist future planning for pandemics. Thank you. And then with obviously you identifying the overview position as you believe the situation got better, can we briefly look, please, at paragraph 66? Because Ms. Killian is detailing within paragraph 66, and we're now at the 29th of July 2020, that the data requested on the 29th of July was not made available until some months later, and her statement, back a paragraph, then effectively says when it was shared, it was poor quality. And so, again, Ms. Killian's suggesting that the issue went on for months beyond the end of July still. Are you aware of that issue?
I think it is the case, and it's set out in 135 of my statement, that by July, directors of public health had postcode level data for positive cases, sex, age, and ethnicity data. I'm quite sure that this was continued to iterate and improve, that it's not sort of, we can declare victory on data at that point, that there was more to do. But my understanding is that those most basic requests that you highlighted in the table earlier on that the department summarised were resolved by July 20. I'm sure that wouldn't have then been game, set and match, nothing else to do. There would have been further work, but I think substantive improvements were made.
Thank you. Can we move then to the second topic that I headline, please, Mr. Garton? And it's any additional assistance you can provide in respect of self-isolation, including the test and trace support payment scheme. Now, I'm going to orientate us just with some things I think that are non-contentious. I think we've already identified that it was a Department of Health Social Care funded scheme paid by local authorities, which enabled eligible individuals or households to receive a discretionary support payment of £500 if they were told to isolate by NHS test and trace.
That's correct.
Thank you. And we know from information provided that it was quite late into the pandemic before this financial support was available. And again, just to summarise again, these are things you tell us in your witness statement. I don't want to go to the paragraphs unless we need to, but if these don't refresh your memory, please say and I'll take you to them. So essentially, on the 19th of September 2020, the department received confirmation from HMT that £40 million of funding would be made available for the scheme from October 2020 and that the department would pay it to local authorities. Then on the 20th of September, the Prime Minister's office announced a new package to support and enforce self-isolation, which included the payment of £500, and local authorities were required to implement arrangements to make the payments as quickly as possible by the 12th of October at the latest. And do you have any views from the department as to why local authorities in reality were given such a short period of time to operationalise the scheme on the ground?
They were. I mean, I have to say they're highly impressive. I think once the ministers had made a decision that this was something that they wanted to pursue, the department played a role with the Department for Health and local authority colleagues in designing a system that, as you say, that was up and running very quickly. My, again, not very profound observation is because they're quite skilled and good at this sort of thing, and they did an excellent job in turning it around so quickly.
Thank you.
But it would have been better, I detect from what you've been saying, had that somebody devised a scheme before the pandemic hit us.
I think if we had, if we knew, I think having optionality before that, I think it's very hard to have predicted in, let's say, February 2020 that we would have wanted a scheme precisely like this without knowing the exact nature of the pandemic. So I think the more that central government can work with local authorities to develop options by which these sort of things can be achieved, the more quickly they can be done. I think in this case, ministers decided they wanted, as the Casey has said, they wanted to see him in September, and actually it was not straightforward, but it could be done relatively quickly.
But quarantine's been a recognised response to pandemics or spread of high consequence diseases for some time now. Dare I say it, centuries even possibly.
Right.
So why should a scheme have to be devised? Surely you can plan for the fact that if you're going to make people isolate or quarantine, whatever word you call it, that they don't miss out and therefore financially and therefore are reluctant to isolate or go into quarantine.
Yes, we can plan for that.
Can I pick up on the questions of Her Ladyship? We know that the United Kingdom called the system Test, Trace, Isolate, but there exists systems research and knowledge that what is necessary for the system to work is test, trace, isolate, support. And you've just mentioned to Her Ladyship that it couldn't have been envisaged in February, that there were the exact terms of the scheme. But from the position of the department, would you agree it was fundamentally going to be necessary at the start of the pandemic for there to be a financial scheme that encouraged and supported those with the least to be able to isolate and stay at home if they were unable to work because of a positive test?
Yes, and I think the shielding programme that the department ran is the best example, if you like, of practical support, of a means for those particularly, but not exclusively, those that were clinically extremely vulnerable, the elderly, that helped them with the basic things like who might not be able to shop online, getting shopping delivered, might be as practical as sorting out someone to walk the dog if they didn't want to leave the house. So I think the shielding programme was set up in the early days of the pandemic that slightly preceded the practical support for those in isolation, and overall was a success. I'm sure there are lessons we can learn and could have been more prepared and would be more prepared next time. We know how to run a shielding programme now. But yes, I agree with the sort of proposition of your question, but I actually think the department did a good job in getting that up and running in the time available.
Who would be responsible for planning, for financial and other support for those isolating?
So
Which department?
So on financial support, that is a combination of the Treasury and the Department for Work and Pensions because of the interaction with the welfare system. On practical support, that was my department, the Ministry of Housing, Communities and Local Government.
Thank you. Mr. Garson, again, there's brevity of time, but certainly your statement deals throughout around other non-financial support packages that were available. So I don't want you to think I'm not cognizant of those things that you've just mentioned. Can we then please look briefly at an email from Mr. Dan York-Smith, who the inquiry will be hearing from next week. It's INQ, please, 585931. And again, this is one of the documents I think that was in your pack, but you are particularly one of the recipients of this email sent on the 26th of June 2020. But it's specifically an email that is outlining the Prime Minister's concerns about the need for financial support for those needing to isolate. And so just again on a topic on the same theme around the delay for a financial support scheme to be in place, and particularly with this email highlighting the Prime Minister's concerns, are you aware why it took until that September, October 2020 to implement that financial support scheme? And in particular, given that the Prime Minister himself was raising concerns in the June?
So yes, my name is on that email in a previous capacity when I worked in the Treasury, so not in the role that I am in currently. I mean, I think the straight answer to your question is there wasn't ministerial consensus that they wanted to proceed with this programme. I mean, that is a fairly standard, not standard, but that is the Prime Minister's Deputy Principal Private Secretary asking for more advice and more thinking. I think that work then happened. And once ministers decided that this is what they wanted, it happened relatively quickly. But the gap, as I understand it, between the June and the September is collective agreement to proceed with the scheme.
Thank you. Mr. Garton, with your assistance once again, can I just display some of the views again of Ms. Killian, please? Could we display INQ 587454, and can we this time go to paragraph 84, please? And again, this is the LGA's perspective on the implementation of the scheme. So if we start at paragraph 84, please. Ms. Killian details as follows. Challenges were present from the outset due to the speed of implementation and the need to refine the scheme in real time. Ministerial concerns and competing objectives across government meant that councils found themselves working with strict but shifting eligibility criteria, which made the scheme harder to administer and led to confusion and resentment as local people perceived a lack of consistency and fairness in who was able to access payments. And just pausing there before I ask the question, you may be aware that the inquiry has collated an Every Story Matters record, and similarly that view as to consistency and confusion and availability of the scheme is one of the themes that has been picked up by the Every Story Matters record. But can I ask you for the department's view about whether you agree that shifting eligibility criteria made the scheme harder to administer?
So the department is not the lead department on the administration of the scheme, so we are to some extent a bystander. But I think it is true, it must be true, that if we ask local authorities to deliver a scheme and the eligibility, the criteria, the conditionality around that scheme change, that makes it harder to do. Because it's not our it's not led by my department. I don't know the extent to which that is the case, but clearly that is a point that Jo Killian is making in her witness statement. And for any of us trying to carry out some instructions, if the instructions change, then life becomes more difficult.
Thank you. Can we display paragraph 85, please? Now, we know that alongside the scheme, there was some availability of funds outside of the set rate. And the inquiry also is aware that Northern Ireland operated a discretionary scheme. But here Ms Killian is detailing, despite consistently highlighting the need for flexibility, local authorities were initially given a small pot of funding to provide discretionary support to support those who did not fully meet the strict criteria in the main scheme, which included passporting from specific welfare benefits set against significant demand. Flexibility was primarily necessary because the criteria for the main scheme required receipt of benefits. This meant that many people at risk of financial hardship did not qualify. And can I ask then, did the department have a role in seeking an alternative for those at risk of financial hardship who did not qualify?
Not that I'm aware of, and it wouldn't be for the department to lead on. I mean, the one thing I would say about the interaction with the welfare system is not something that I'm expert on, although Daniel Smith would be much better than me. It is immensely complicated. And the minute you put benefits over a certain level, and does this count as a benefit, that has all sorts of other implications for people on universal credit and the like. So it is not straightforward trying to run the welfare system in a fair and consistent way. And the lack of, although I'm generally an advocate of discretion for local authorities, the lack of discretion given to local authorities here may have been for very, very good reason, because you don't inadvertently want to make somebody ineligible for universal credit or another benefit.
Thank you. Could that be removed from the screen? Topic 3, please, Mr. Garton. Disproportionately impacted groups. And again, you say and tell us about paragraph 151 that the department considered the adverse impact on disproportionately impacted groups, and this included the introduction of the Community Champions Initiative, and that's detailed within the statement. So I don't want, in summarising, asking you focused questions, to not be looking at positive things and things that went well.
Yep.
But can I ask you then, what is the department's assessment of the success of the scheme of the Community Champions, please?
So many people in this room will have their own views. I mean, we think it was a success, and I think we have done independent evaluations which show that it worked. It was locally led. We allocated money to 60 local authorities, and I think that was overall a positive experience. I understand, although I understand outside the vires of this particular module, that much of that was carried into work on tackling vaccine hesitancy. So good practice was continued into a later stage of the pandemic. So overall, a good thing, I think.
Now, the detail in your statement tells us that the Community Champions scheme allowed local authorities to be responsive to their community and to recruit these community champions. But can I ask you, instead of delivering a new scheme, do you know whether there was consideration given to utilising the pre-existing community networks, local representatives and organisations?
My understanding is that in order to run the most simple and effective scheme, the department's view was that by allocating money to local authorities, that they in turn could engage with the community and voluntary sector, because quite often they would have those existing relationships, whereas if the department tried to go around local authorities, that would make the process more complicated and more likely to fail.
Thank you. Can we briefly go to your paragraph 388, please, on page 97 of your statement? Thank you. And again, this is the lessons learned aspect of your statement from disproportionately impacted groups, where you tell us about the final meeting on the 8th of December 2021, and that included a presentation on lessons learned. But can I ask you, do you have any views, or the department, as to whether more could have been done prior to August of 2022 about the insufficient focus on disproportionately impacted groups?
I think you're hearing from my colleague Emran Mian later in the day, who was responsible for this work, so he will be more articulate than I am. I mean, when I look back on this, the obvious question to me is, could we have done it sooner? It seemed to work, but summer 21 is late. Summer 20, forgive me, is late. And I think that when we reflect on what we could do better next time around, this is certainly the sort of thing that we would want to repeat, but I think we'd want to do it faster. But Emran would be better on this than me.
Thank you. Could I move to an aspect of topic 4, please? I'm going to have to cut my cloth, but can I ask you briefly about contact tracing? That can be taken down, please. But can we go to paragraph 201 of your statement at page 51? Thank you. And just to identify, you explained that NHS Test and Trace work directly with local government to carry out contact tracing via the local contact tracing partnership model. And later in your the next paragraph, please, you say that the department's role was to support local authorities and understand any emerging issues with local tracing partnerships. But can I ask you then, one of the issues appears from the inquiry that certainly when the test and trace scheme, particularly from the March and what was implemented then of test and trace in May, that there was an underuse of the contact tracing resources in local authorities and in the Directors of Public Health, and it went to the centralised contact tracing model, albeit that then, I think as the months progressed, the local resources were brought in.
Yep.
Was that something that the department had identified in the creation of the strategy of test and trace?
Less so on this, but we're less involved. We had more of a watching brief on this one. This was largely a direct relationship between NHS Test and Trace and local authorities. But again, I think one of the learnings for us is simple things that people, I think it is true, that people are more likely to answer the telephone from a local number and perhaps more likely to engage with somebody on the phone if they feel they're from their part of the world and not a million miles away. So those are all things that I think we could look to do better and be prepared for next time, but this was more of a direct relationship between the NHS and local authorities.
Thank you. And that helpfully moves us on to topic 5, please, which is just a little more exploration, please, of the centralised versus local TTI system. And can we use Mr. Fell's statement, who's provided the corporate statement on behalf of the Association of Directors of Public Health? And can I go, please, to INQ 587434, and it's paragraph 102, please, I'd like to go to, please, which is at page 24. Thank you. Thank you. Mr. Fell has provided evidence, and we will hear from him in the final week of the inquiry. During the pandemic, especially in the early stages, there was a significant disconnect between how policy was formed nationally and how it was implemented on the ground. The top-down approach by government meant that directors of public health were sidelined in terms of the national decision-making and centrally run programmes such as testing regimes. There was an assumption decisions could be made at a national level that would be suitable for all local areas, and that proved costly as the one-size-fits-all approach was not effective. Can I ask you, from the perspective of the department, do you agree with that analysis or have any views on it, please?
They're not words that I would use, but I recognise that over the course of the pandemic, we moved. There was an evolution from quite a centrally run process in the early days, and there may have been very, very good reasons for that, and the Department of Health and Social Care will want to articulate them, to a more localised approach. That localised approach was sort of best summarised, I think, by the Contain framework published in July 2020. On the specific issue of community testing, I actually think when we moved to a community testing model, it was at least the case that I think we started off in Liverpool and looked at the possibility of whole population testing. And we got strong feedback through the R9, one of the groups that we use to engage with local authorities, that whole population testing in Liverpool or any other place for that matter wasn't the right approach, that it needed to be more targeted and more specific. And I think, to be fair, the NHS test and trace architecture then changed to respond to that feedback. So a slightly more positive take is an example, to my mind, of central government listening to feedback from local authorities and evolving the programme as a consequence.
And just with, I think you've looked at it through where I think the test trace scheme had developed, certainly to the end of 2020, when we get to the community testing programme. Could I just ask for any other clarification you wish to give? Because I'm more perhaps looking at the period of time from the March to the May and the announcement of the initial strategy of contact tracing and test, trace and isolate, where it very much was starting a contact tracing system from scratch, using a centralised, well-staffed, I think there's talk of 20,000 or so contact traces in a call centre, as to whether there's any exploration or additional things you want to say about not the end period where it ended on community testing, but the period of time when the strategy was implemented in the May.
So I think it's an excellent question. I don't think I'm the best person to advise the inquiry on whether that was the right thing to do or not. I have just some hesitance that it would be possible to go to an entirely local approach too quickly, because we just talked about the need for data to be interoperable, I think is the phrase, and collected on a consistent basis in order that it is any way meaningful. So I think that some national infrastructure has to kick off a nationwide, a global pandemic, and has to be in place. And you've got 152 local authorities in England. It would be a disaster if we had 152 different systems. Now, I don't think anyone's really proposing 152 different systems, but you do need some consistency, coordination, ability to compare and contrast. So the sweet spot that I think we are all looking for is how do you have that consistency, coordination, and ability to compare with a local element. I honestly don't know whether or not that was possible prior to the summer of 2020. I'm afraid that's something that colleagues in Test and Trace would have to advise you on, but I don't doubt that it was a complex operation that they were trying to undertake.
Thank you. Again, with your indulgence, please, could we briefly then look at comment on that central local tension that's provided in a witness statement we've received from Jennifer Dixon of the Health Foundation. It's INQ 475185. Thank you. Paragraph 82. Again, this was in your pack. And you can see that within that statement, it's provided that the balance between national and local leadership of England's test and trace regime was a recurring challenge which failed to strike an optimal balance. I think you yourself have identified the desire and drive to try and find that sweet spot. Is there anything else you'd wish to comment upon in the context of this further statement that highlights the issue of the central-local tension?
Just to say, I think the LGA recognised that it did improve and it changed, and the appointment of a chief executive of Leeds City Council to run the system, I think, is a really good example of staff from central and local government becoming more and more interchangeable, and from that I think we can derive huge policy benefits.
Thank you. Now, that can be taken down, please. I'm at my topic 6. I've already headlined the very detailed witness statement you've provided. Annex B and C contains the various documents that the department considers reflect learning, and I'm not going to ask you to even try and put a framework on that. You've already helpfully flagged one area where you think there is still a potential area for the work to be done on protocols in peacetime that look at the issue of data access and sharing of relevant information needed in a pandemic. I think you've revisited it a number of times in your evidence, but is there anything else you'd wish to add to that potential recommendation for Her Ladyship's consideration, please?
No, I don't think so. I think that's fine. Thank you.
Mr. Garton, thank you very much indeed for your assistance. Those are my questions. My lady, there are some questions.
There are. Thank you very much. Ms Monroe, I think it's you.
Thank you, my lady. Good afternoon.
Good
Mr.
afternoon.
Garton. My name is Alison Monroe. I represent COVID bereaved families for Justice UK, and I just have a few matters I'd like to deal with, some of which you've touched upon, so hopefully I can take these quite swiftly. Firstly, thank you for setting out in your statement and your evidence this morning the role the department plays and the interplay with other departments and in some instances, the conduit role that your department may play. So looking at test and trace, I don't know if you were able to catch any of the evidence yesterday from Professor McKee.
I saw some of it, yes.
He's provided, obviously, as well as giving the oral evidence, a witness statement to the inquiry, and he's a member of Independent Sage. In that statement, he states that, quote, "We emphasise the need for a test and trace system rooted in local communities, integrated with the NHS and led by local directors of public health. We argued that the current private sector-run NHS test and trace system should be replaced with a more effective model that leverages local knowledge and resources. We were aware of the actions taken by directors of public health in Leicester and subsequently emulated by his counterpart in Sandwell and others that have proven very successful in overcoming the significant weaknesses in the national system. And just to help you, Mr. Garton, to contextualise, he exhibits MMK 24A INQ 000574992 for the record, an exhibit which he sets, which is basically, I think it's a blog account of how things were done in Leicester and Sandwell, and effectively they took control. I mean, they literally say, we took control. This is what our public director of public health did in Leicester, and it was very, very successful, tapping into local resources, and Miss McNally, the counterpart in Sandwell, did the same. Now, touching upon, the question is, and I'm mindful of your last answer about finding the sweet spot between national and local, but would you agree that with what Professor McKee says, that the system should be rooted, not exclusively, but rooted in local communities and led by local directors of public health? And that would be preferable to the highly centralised model that government opted for in May of 2020.
So I think it's an excellent question. I'm slightly freelancing on Department for Health and Social Care policy, so I'm going to be a little bit careful. Look, rooted in communities, yes. I'm somebody that spends most of my working life going around trying to persuade people for a more localist approach. I have some nervousness on things like capacity in local authorities. A lot of local authorities are struggling financially hugely at the moment. Too much variability in data collection, security and the like. So I think if those things, and consistency, if those things can be, we can have assurance on those things that I think the centre can do best, that we wouldn't want to do 152 times in each local authority in England. There's a process of local authority reorganisation happening in England at the moment that's making it more complex. So I think there are risks to an entirely local approach, and I say that as a localist. But I am sure that we can do more once we have the basic tenets in place of consistency, security, capacity and the like, to make sure that we use the data that we have to enable local authorities to serve their populations because, as you've articulated, they tend to know them best.
Thank you, Mr. Glaston. And then my second question, still on this topic, was your department aware of the actions taken, for example, by the Director of Public Health in Leicester? And I can, again, contextualise it for you by just reading from that exhibit. It says, on July the 14th, Leicester took matters into their own hands and set up their own local contact tracing system. It worked in concert with the NHS Test and Track, taking over local cases that the national system call centres struggled to reach and tracking them down on the phone and physically going to people's homes. The Mayor Peter Salisbury said that the city's local contact tracing system managed to reach about 90% of the cases it handled. He asked for more powers to be given to local authorities in regard to the handling of the pandemic. So that gives you a flavour of what was going on in Leicester. Was that something your department was aware of at the time?
Yes, I think so. And I think it's one of the really impressive pieces of practice that was run and initiated from local government, and shows just how powerful a role local authorities can and should play.
Thank you. And finally, Mr. Garden, do you think that the proven successes of the local initiatives, such as the one of Leicester and also Sandwell and others, led to any changes in the approach to test and trace, or the support and guidance provided by your department at the time?
I think those examples of success meant that the gradual localization of the pandemic, if I can describe it like that, the central government had more confidence that that was the right thing to do because there were these examples. So I think that they help definitely, and I think the question for us, as we've discussed today, is could we get there more quickly? How do we get to a more mature relationship where we are using the benefits and expertise that exist locally in order to try and protect, especially the most vulnerable in our communities?
But I suppose the point that those I represent would really want to know is, you've mentioned the variabilities, data, consistency, sometimes resources, because local authorities are very hard done by in terms of funding. Knowing and seeing those initiatives locally, Leicester, Sandwell, etc., and the successes that they were achieving, was anything done in terms of the government considering more resources, looking at the consistencies and bolstering those systems?
Yeah, so I think yes, I think is the straight answer to your question. Part of that, the most obvious example of that, is one of the things I think actually the department and the government did relatively well during the pandemic is fund local authorities properly. You're absolutely right. There is not an excess of cash in local government. We've got many local authorities in exceptional financial support at the moment. But in addition to the Contain Outbreak Management Fund, the department put about £6 billion into local government during the first 2 years of the pandemic. That money was weighted towards local authorities that had higher levels of deprivation. And I would say that it was good practice in that it was unring-fenced, non-conditional funding, and that made it easier for local authorities to fund initiatives like the ones that you identify in Leicester and Sandwell, because there was that proper baseline level of funding that went in.
Thank you very much, Mr. Garden. My lady, thank you.
Thank you, Ms Monroe. That completes the questions we have for you, Mr Garden. Thank you very much indeed for the help that you and your department provided in the written statement, and of course the help you've given this morning. I know the burden the inquiry places on government departments, and we couldn't operate without the cooperation of organisations like yours. So thank you very much.
Thank you very much.
Very well, I shall return at 10 to.
Thank you, my lady.